Here we are in Ways and Means. It is still Tuesday, January 27th, and it is 2:45. We are continuing our conversation about the impacts of the summer's federal legislation. And one piece that we have not dug into yet is the changes to the provider tax. So we have our healthcare team here to tell us all about it.
Great. For the record, Noel Nyla, the Joint Fiscal Office.
And Jen Carby from the Office of Legislative Counsel.
So can't really start talking about provider tax until I do a really quick background of why does it matter.
Yes, please.
So provider tax, they're healthcare related taxes. They're just referred to as provider taxes. And we'll show you in a future slide which providers actually get taxed. And as you know, Medicaid is financed as a state federal partnership. Provider taxes are used to help generate revenues to draw a state match to help pay for the Medicaid program. But they must comply with federal laws, and that's why Jen is here, because you'll have questions about the law. And then Jen and I like to say, I do numbers, she does words. I didn't go to law school. So provider taxes are deposited into the general fund. They used to be deposited into the separate fund called the State Healthcare Resources Fund, but now they're in the general fund. And I have this slide up because I want to give you a sense of how much, when you think about the Medicaid bucket or the pie, how much of the general fund pie provider taxes account for. So the left side are the state only. Of all the general fund dollars that we raise, provider tax account for 28% of the total state dollars that we use to pay for the Medicaid. 88% are general fund or other general funds. And then we have these other state funds. So that's special funds, some other pieces. If you look at the whole bucket and you throw in the federal piece, you can see provider taxes still account for 9% of the money you use to pay for our Medicaid. So that's why it's important. So I don't remember the last time I did a presentation on FMAP, Federal Medical Assistance Percentage, but basically that is the formula that's used to calculate the state federal match. We have multiple match rates. Our regular normal match rate for the majority of the program is this 58.81% federal and 41.2% state. This is the state fiscal year 26 numbers. So to translate that, for every $1 of state dollars we put in, we draw $1.43 of federal dollars for a total gross of $2.43. So translated, $1 of state dollars means $2.43 of service. Now it goes the other way. When you cut a Medicaid dollar, you lose $2.43 of service. So it goes both ways. We have other matching rates for our children's health insurance program. That's about 4,400 kids. That's about a 70-30 match. And we have this group called the Childless New Adults. They're not new. It's just the title that was given to them when it was part of the Affordable Care Act expansion. But this particular group is a 90-10 match. We've got 41,000 childless adults who get this match. So just to give you a sense, and then I throw this one in here. This is the 27 FMAP rates. It's actually gone, the FMAP has gone down, which means the state share has gone up, which means that we have to pay, I think it was an extra $15+ million per year just to level set for the current programs. The FMAP goes up, it goes down. It's this calculation that's done by the federal government. I can do a whole presentation on that, but I won't today. Jen's going to talk about the federal parameters.
Yes, so for provider taxes, we're allowed under federal law to tax up to 19 different types of services. We do fewer, and Nolan's got slides coming up that show those, what we do and what we don't. But there are certain requirements around provider taxes. They must be broad-based. So if we tax a class of providers like hospitals, we have to tax all hospitals. We can't say we're going to tax certain types of hospitals and not other types of hospitals. There are some questions in another committee about physician services, which we don't tax. But if we did, we couldn't say we're not taxing the primary care providers. We're only taxing specialists or gastroenterologists, cardiologists. So they must be broad-based. If you pick a class to put a provider tax on, it must apply across the across the whole class. And similarly, the provider tax must be uniformly applied. So if you pick a class to apply a provider tax to, everybody has to get the same tax rate in that class. So it's the same licensing fee or the same per bed fee or the same percentage on gross or net receipts, things like that. And then finally, you must not hold providers harmless. In general, the idea behind provider taxes is to tax providers to generate revenue that then can be matched with the federal matching funds from the percentages Nolan was showing you. And then the funds are redistributed to providers through Medicaid rates. So when they get paid for services, that's how we've generated a lot of the money to pay them for the providers for the services that they provide. But we can't guarantee them directly or indirectly that we're going to hold them harmless. We can't say, you pay us this amount in provider tax, and then we'll get the federal match, and then we'll give you back the amount that you gave us and make you whole. So there are some winners, there are some losers for the providers, depending on what their payer mix is, how many patients they have that are on Medicaid or on other types of coverage or no coverage. So we can't guarantee providers in any way that we will return it to them to make them whole. There is a presumption under existing law that, or previous law, that this requirement is met if we don't tax at more than 6% of net patient revenue. So if you have a tax that's higher than that, the feds reserve the right to poke around and make you prove that you have not held anybody harmless. But if you set your rate at 6% or less of net patient revenue, or the equivalent for different types of taxes, then they have historically said, we're just going to take you at your word that you're not holding anybody harmless. And as we'll go over in future slides, this provision starts changing in fiscal year 2028 as a result of HR1, the Federal Reconciliation Act, that was passed in July of 25.
I want to be patient for slide 11, but when you refer to this provision, do you mean the final bullet or the whole slide?
The safe harbor, the percent piece.
Okay, thank
So
you.
yes,
Great.
so not helpful to our finances. Things happen with the percentage.
These are the classes that we can tax. If they're in red, they are on the books in Vermont. So if inpatient, outpatient hospital together, that is our hospital provider tax. We also have nursing home facilities. Now this intermediate care facilities, we actually don't have any anymore. It's still on the books, but we don't have any.
I mean, we don't have any actual facilities, not we don't have any taxes on this.
We have no facilities left
We
anymore.
don't have any facilities that are licensed as, these are intermediate care facilities for individuals with developmental disabilities, and that is no longer how we do licensure for those types of services.
We have one for outpatient prescription drugs, and then we also have one for emergency medical services. This slide shows you,
Sorry. It's only chiropractic services of physicians?
That is a category. So you can see physician services is a category that the feds allow. Chiropractors are not physicians. They're chiropractors. So you could do a provider tax on chiropractors. You could do a provider tax on podiatrists, optometrists.
physician
Yes.
services.
Does that make sense? It's not a subset of physician services.
Thank
It's
you.
just a different type of service.
And so the rows are not,
Yeah.
they're not rows, it's just a
It's
list that's
19
fitting
independent
into
boxes.
the type, yes.
Many
Thank you, okay,
independent
cool.
boxes, sorry.
I've been with Julia too long.
Is there any reason why some boxes were selected and others were not?
That gets into the history. What I can say from anecdotal from our years here was like, there were agreements with those particular providers. And when they were done, they were negotiated with those providers. So for instance, nursing homes, and I'm actually gonna go to this next slide. Nursing homes, you'll see, some of these are 6%, 3.3, but nursing home, it's per bed. And it's because when it was being implemented with some nursing homes, they were like, it's a lot easier for us to just do it on a per bed than like our net patient revenue. We know it's below 6%. But another story that is back during Governor Shumlin, there was a proposal to do a provider tax on dentists. And the dentist did not want it. And one of the reasons it sort of failed is because, at least with like nursing homes and hospitals, there's not a lot of them. And they have to report a lot of their cost data to the state. Whereas dentists are privately owned, independent, they don't have audited financial statements. They don't have to report stuff to the state. We don't know how many of them there are. We don't know how much revenue it raised.
Do you know how many there are? Because we license them.
Oh, but you know what I mean?
They pay taxes already because they're businesses.
Yes.
That's,
But this is a tax on net patient revenue,
Okay,
which is a different type of tax.
sure.
But anyway, it failed. Part of the reason because the complexity of how would you implement it? We didn't know. It was just, and then they were resistant to it versus emergency medical services. That's the newest one we had. And that was at that time, the providers wanted a provider tax. So they worked with us to come up with a way to figure out how to tax them. So a lot of it had to do with cooperation with the industry and desire within the industry to do it as a way to sort of help raise money to increase rates for that industry.
Can you go back to the
okay,
slide before?
that's why you want a tax.
So some of it's the like wisdom of the body, but some of it might be like services that receive more Medicaid dollars, so might feel more interested in having more Medicaid dollars in the mix.
There is that too. Where dentists have a lower Medicaid mix.
Fewer dentists.
No, now I'm stuck in like hypothesizing what past legislatures did, which seems like a terrible idea to try to imagine. Yes, Representative Bodie.
Thank you. So there are reasons that you would want a provider tax in your segment. One is, it would allow the sector to raise money, they could increase rates. Was the other so that they could provide more services to Medicaid patients?
No, so when when the EMS providers were negotiating the reimbursement rates for some of the things they're doing on the lower side, and it was a way to raise money to put back into increased rates. To Jen's point before, we talked about how you can't say, okay, you gave me $1 million, we're gonna make sure you get $1 million back. If you pay a money and you have a high Medicaid payer mix, you're gonna get more back than if you are a low Medicaid payer mix. But it's not how the providers use that money. It's all in the rates.
Medicaid provider mix means.
So if you have
In your class.
no, payer mix is like, I am a business. I have Medicare, Medicaid, commercial. If I'm a business where a lot of my business comes from Medicaid beneficiaries, I'm going to do really well because I'm going to pay the provider tax on the total net patient revenue of all my payers. But if I have high Medicaid, I'm going to get more Medicaid back versus if I have a very heavy commercial and not a lot of Medicaid, I'm paying provider tax on my total across all the different payer mixes. But I'm not getting a lot back in Medicaid reimbursements because I don't have a high Medicaid population in my.
So can I ask a follow-up? So if you wanted, as a policymaker, to encourage more dental practices to serve Medicaid patients, would you want a provider tax?
No, you would want to increase reimbursement rates for dentists.
And one way to do that might be creating a provider tax.
Arguably, one way to do it could,
Right.
it also depends how many dentists you'd have who were actually, paying in, and whether that is significant enough to affect the rates.
You're on the right track though. I
Yes.
see where you're trying to go.
Yes, but don't get too excited about new provider taxes, because
Yeah, wait till the final slide. Guaranteed to bring you right down.
Oh.
All right, so these are the different provider taxes that we currently have. So hospitals are 6%. Our 26 actual rate, 212 million. We forecasted the rate 225 million for fiscal year 26. Hospital provider taxes are the bulk of our provider tax money we raise. Nursing homes are 14.4 million. Ambulances are about 1.4 million. And pharmacies we raise about between $800,000 and $900,000 per year. Home health, we sunsetted back in 2023. So as you can see, hospital provider taxes account for about 93% of our total provider tax mix. A couple more slides before we get to the grand finale, though. It's like watching the fireworks and you're just waiting for that finale where all the fireworks go off at once.
How I feel right now.
No.
Yeah.
It's like a picnic blanket.
Yeah,
You're around.
exactly. So in 2004, there were 35 states that had provider tax. In 2024, 49 states and the District of Columbia had at least one healthcare provider tax. The most common was nursing homes, followed by hospitals. And approximately 13 states, including Vermont, had a provider tax rate of more than 5.5%. And 20 states had provider taxes for hospitals that were less than 3.5. So you can see how states are using it and what they're using it for kind of varies all over the map. And then 32 states have intermediate care facilities, and we don't have it yet.
I'm just curious, who's the one state that doesn't?
I think it's Alaska. I believe it is Alaska. So, one of the slides you've been waiting for. What did you do?
So one of the things that the federal legislation does is it phases down that maximum, that safe harbor, or really allowable, and I think it's beyond even safe harbor in what they've done. They've phased down that 6% cap, 0.5% a year over several years. So we go from 6% down to 3.5% by the time they're done ratcheting it down.
Can I ask you a question about that?
Yeah.
So it's very unusual for the federal government to limit our ability to tax. And so I just want to make sure it's really like the limit to tax is not the limit to tax and use as match.
If we are taxing providers, that we are sort of presumed to be using it for match, whether we actually do or not. It's just it's a provider tax.
That we must be using for match.
That is regulated by the limits on provider tax. I looked
Okay.
at this a little bit too. It's like, could we, shift things around?
Like maybe we could dedicate it to the transportation fund.
Yeah, no, not on.
Thank you, everyone. I was like, that is a delayed laugh. I deserve a laugh for that one.
Nice idea.
Thank you. Thank you.
Yeah, so I believe it is.
Okay, thank you.
If we are going to tax providers, these are the.
There's just a presumption that it's, okay, thank you.
And Jen said, no, we can't do that. Why?
The federal government.
Oh, that's.
Because that's part of the federal law.
The new federal law that passed this summer.
Yeah,
Yes, I mean, actually, the provider tax limitations, I think, are just the provider tax generally, but they, on this particular one, are ratcheting down our max rate. So it freezes our existing rates and then ratchets them down. So, and you're going to talk about in Vermont?
sure. Yeah. So in Vermont, this only affects the hospital provider tax. And that's because nursing homes and intermediate care facilities are excluded. And then the other provider tax that are left over are below 3.5% in Vermont. So it really only hits the hospital provider tax. Now, to all the questions before about what if we want to tax this provider or that provider? Well, now under HR 1, like Jen just said, it freezes it. We can't increase any existing provider taxes to go higher, so we couldn't raise the ambulance provider tax. And we can't institute a new one like dentists, or Chiro, like it freezes them in place. Now, one of the reasons the federal government is because people, and when I've done this before, they go, well, why are they even doing this? And I can't say why they're doing it. You can't pinpoint it, but what you could say is the federal government has booked significant federal savings in the bill under the assumption that states will be raising less money to draw less federal match. And that's where the savings are on the HR 1 bill.
And some of these provisions only apply to states that expanded Medicaid eligibility under the Affordable Care Act.
Right, only.
Some additional provisions.
Yeah.
So is this 6% for the hospitals? All picked up by the insurance?
No, it's the net patient revenue. So it's the revenue across all payers.
When the hospital pays?
Hospital
Yes.
pays.
Yeah,
You're thinking the claims taxes the insurance company pays,
yeah.
but the hospital pays the provider.
Okay, so it must reflect on the patient's bill somewhere. Or does it?
It's probably built into charges and negotiated rates. And I mean, yes, they have to find the revenue to pay it somewhere, but I don't think there's a line item on your bill that says this amount goes toward the provider.
Especially because it's, we take the revenue. And if they're adding money for the provider tax and the revenue, then we're taxing them on the provider tax revenue. It gets confusing, but it's cyclical.
Yeah.
And it's from the previous year. You look back.
Thank you.
So the hospitals must be
Michael.
happy with the rate decrease. But then, how do you make up for the decrease in Medicaid payments?
Therein lies the question. So it's a good transition to the next slide. But I don't know, and I don't want to speak for the hospitals. But it's a mixed bag because they will have a lower, their provider tax rate will go down, but resulting, if you have, the way I describe it is you have three levers. You can raise taxes, you can cut services, or you can find efficiencies or find money elsewhere in government. In reality, the federal government is assuming that we'll cut or reduce our Medicaid spending, which means that we're going to have cuts to Medicaid. Cuts to Medicaid may increase uncompensated care in hospitals. So they might have a less of a provider tax, but they might start seeing more uncompensated care that they have to, free care that they have to compensate for. So I don't know that you could articulate or assume that it's a win for them. So this is the impact. This is the Nolan JFO moving target. If you know, it's interesting because AHS, they have a similar chart. Their numbers are slightly different, but I like to say they're not really that different. They're similar, and it's a moving target, and we won't know until we know. But in essence, this is state fiscal year. You can see it doesn't start till state fiscal year 28, and we're assuming that the first year will be about $15 million reduction in general fund. Second year, 35 million. By fiscal year 30, 57 million. You can see that when it's fully annualized by fiscal year 33, this is in today's dollars, we assume it to be $113 million. But this is like in today's dollar and steady state doesn't take into consideration any healthcare reform. Yeah, doesn't take into consideration. Well, I take that back. I do assume it's today's trend because I do assume an increase in net patient revenue of 3% each year. So it's actually not completely today's dollars. But it doesn't take into consideration any policies or healthcare reform or anything we can do to start reducing rates. It's just sort of like steady state based on today's policies. That's probably a better way to say it.
And so this is just a straight loss in revenue to the state is also not creating sort of the multiplier of losing the match if we decide to lose the match.
Yeah, this is assuming just a state match because
There's a policy decision that we would then make about whether or not we would reduce our spending and
Correct.
reduce the match. Okay. So if this is just a reduction in revenue, it wouldn't necessarily, but we keep spending somehow magically the same. It wouldn't be a loss of also revenue to the hospitals.
yeah, I mean, I see where you're going.
If we lost the match, it would be a loss of revenue to the hospitals.
Yeah, I can't, yeah.
Okay, but we would still have to make that policy decision for that to happen.
Right. Loss to the hospitals, so 113 million times 2.38.
It's not lost to the hospital, it's lost to the state is the one, and then it's a loss to the system.
Yes.
Because not just hospitals that are getting this money, it's all the providers that get Medicaid match. So it's a reduction in the system. If you were to say, we're just going to cut the equivalent amount versus raising revenue or finding money from within government or efficiency. Like I said, those are the policy lever choices that will have to be made by the governor or legislature as we move forward, unless things change at the federal level.
So I just want to make sure I'm a little slow here, make sure I got this. If you're going down 100 million by 33 and you assume like FMAP rate of, I mean, if I look at your numbers on the previous slide, the total revenue is twice that we've lost for the system.
If you assume,
Really.
That's what I'm trying to find out.
so again, that's if you assume that we're not gonna raise revenue, we're not gonna offset it elsewhere, we're just gonna cut that equivalent of general fund, then you're looking at about $275 million across the system. But again, that's up to whatever policy leverage you choose.
No, yeah, that's that.
One can argue it as much as. And again, those numbers will start coming to fruition once policy goes into effect.
So right now, like, and, you know, those policy decisions are a little bit outside of this room, but the reality that like we're responsible for the revenue of the state and we're about to lose a lot of revenue is sort of
Right.
why we're hanging out here.
Yeah.
Representative Higson.
Thank you. You said some key words there, unless things change federal. I think it's interesting that this start date is the fiscal year 28. Any particular reason why it was pushed out for 4 years?
I can't speak to the federal decisions.
I mean, we've heard in other testimony that like a whole lot of the implementation dates of the federal bill this summer start after the midterms.
I say, well,
Start after the midterms and you can take whatever from that you want to, but that's the reality of a lot of the start dates.
Just a policy question. If we did not reduce the provider tax from 6 down to 3.5, is it that the federal government would then just take that into account when figuring out the Medicaid match? It's not that the state would be liable for anything on a legal basis, but
We are just prohibited from imposing a tax at rates higher than whatever they ratchet it down to. So it says the cap.
yeah, but prohibited only in the sense of what gets matched, correct?
No, this is the tax we can impose on the hospitals.
Prohibited.
Yeah, I agree with you. I'm just trying to
Work around it.
figure out, it's a federal ban on a state tax.
The federal cap on the tax rate.
Which I don't think they do on anything else. It's kind of fascinating.
Do they do have anything else?
Don't, getting outside of healthcare here, I don't know. Not healthcare.
But what happens if you don't lower the rate?
It'd be out of compliance with federal
Yeah,
law.
we'd be out of compliance. I think they would. I mean, I'd have to look at the Medicaid law, but I think it would not go well for our expectation of match on
That's.
funds. I mean, I don't know what the specific
Yeah.
levers levers are on this. We don't defy them on these issues.
Yeah, to Jen's point, they could just say, we're just not gonna match it.
Right.
They could also
Right.
say like, we're suing you because you're in
Yeah.
violation of federal law, right? It's,
Let's not find out.
Right.
well, you know, sometimes we do need to find out. Representative Page.
So it doesn't matter what you call it. We added 3% tax to the hospitals and called, I don't know, Sun and Fun tax or something. We couldn't do that. Is that correct?
That's my understanding, and I'll look at the language again of the federal law, but it seems to be just generally the state's taxation of the listed providers. Not for things like property tax or whatever else they get taxed on, but
I mean, I will offer that some states extend their sales tax to services, and sometimes healthcare providers are considered one of those services
Right.
that the sales tax gets extended to, and that is considered a sales tax, not a provider tax. But I wouldn't want to talk about it in the context of this right here, because that could get a little confusing in the future.
And I don't imagine, I mean, is there any legal hoops that are, going forward that maybe the Attorney General's looking at?
I'm not aware of any because this is a wholly federal provision. So I'm not sure what we would be suing on other than we don't like it, and that's not generally.
I mean, it is interesting that it is, I think it's worth us finding out if there are any other places that we are limited on taxation. Yeah, Representative Brannigan.
So if we, worst case scenario, if we accept this 3.5% as a cap, and we accept the loss of the 113 million by 6 years out, what do we lose as far as services in the hospital?
Again, that's similar to the question that was asked earlier. It's depending on what policy levers you choose. If you were to say, we're just going to cut all that money out of Medicaid, then you're looking at about $275 million worst case scenario of services cut in Medicaid. Now that might be cutting eligibility, it might be cutting services, it might be reducing reimbursement rates. It's a whole slew of things that you might be doing. That's why I said you have policy levers. You can look at your revenue sources, you can find efficiencies, you can, whatever, that's the policy levers.
So if we can find a way to make it up from revenue from someplace, that would be legal,
You're not taxing the provider.
not taxing the provider, and that's the hospital.
Yeah, if you find other revenue sources that are not provider tax and put them in the general fund, then yes, you can use them.
So the federal law says as far as a healthcare related tax, a healthcare related tax is a licensing fee, assessment, or other mandatory payment that is related to healthcare items or services, or the provision of, or the authority to provide the healthcare items or services, or the payment for the healthcare items or services. And a tax is considered to be related to healthcare items or services if at least 85% of the burden of the tax revenue falls on healthcare providers.
But you kept saying services, so that zeroes out Amy's idea of provider services.
I'm not sure how, I mean, they may be doing it at such a level that currently it is permitted under the provider tax statutes, but wouldn't be.
I want to be clear, that was not a proposal. That was just
Yeah.
like a random.
You know, if it's a 5% tax on services, then maybe that's permissible under the existing scheme, but won't be at 5% as it goes down to 3.5%. But I don't know enough about how they're structured.
One last thing, sir, dumb question, but HR 1, that's the big beautiful bill.
It's pretty much.
So then Representative Odie. and then-
Looking at this timeline, do we have to act before 2028?
There's nothing that you have to do before then. No, but when you see the governor's budget for fiscal year 28, you'll see the assumption of loss of revenue. There'll probably be some language changes to comply with federal law. But in fiscal year 27, there's nothing you have to do other than be mindful on the appropriation side of any increases in base spending in healthcare fields.
And it does look like it is a reduction in federal financial participation if we do not stay within limits. Just confirm.
And we just, if we are interested in doing something about it, I genuinely have absolutely no like proposals, schemes, ideas about something to do about it. Most taxes take a couple years to implement, and so we would need to start the conversation now if we did want to do something about it. Representative Odie and then Maslin.
After what you said,
You
I
got new
don't
glasses.
remember why I had my hand up before, but after what you just said, you could make it, since it's not even going to start taking effect till 28, you could say whatever thing you put in place to raise the money somehow otherwise, that is not against the law, would only come into effect if this went forward.
Hmm.
And the first year it's small, $16 million difference, so you could suffer the 16 and then.
We only have 15 months from now in order to stand up a new revenue source.
If that's what we're talking about.
Right, it's kind of interesting to think about.
Yeah, why do we?
Representative Maslin.
An old question from a number of minutes ago, you said, if this stuff comes to pass, we may see a decrease in net revenue to hospitals, and they gave 3 reasons that I wrote down, except I only wrote down 2. Reduces a Medicaid match, we've been talking about that. It'll be less on.
Should you talk a little bit louder? I can't really hear you.
Reduces in Medicaid match, FMAP. Reduction in uncompensated care that will cost the hospitals, and there was a third thing. I wrote down the wrong words, but
Well, I said those things in different contexts, each individual in different contexts.
understood. But there was a third thing. If this stuff comes to pass, that'll cost a decrease in hospital revenue.
Well, so the question there was from Representative Page, when he said that the hospitals will be happy about this, and I was saying no, because if they have a reduction in their tax, but they could see an increase in their uncompensated care.
Right.
And then the payer mix was in response to Representative Odie's question about how people, when they pay the provider tax, how do they see it back? And then the other piece is just, I think I'm just trying to link your
Oh,
question
maybe.
together, was like, what are our levers? If this is the law of the land, so I would say when this comes to fruition, your levers for offsetting it are make cuts in Medicaid, increase revenues, or find efficiencies or money from elsewhere within state government. Those seem to be your major levers to
Okay,
trying to help string your stuff together. I'm sorry for not answering the question.
no, that's right. It all fits. there was another phrase you used that
Hmm.
made sense up here, but I don't have it
I'm
with
sorry.
me at the moment. But that's okay. This is a good explanation of how it's gonna work or not.
Yeah.
Thank you. My understanding is, there's some changes for qualifications for Medicaid folks.
Yeah.
How does this fall into the relationship with us?
There were some, we have a whole presentation on that, but there were some changes in eligibility, some around folks who are immigration status. There was one around, you just brought it up my head, that changes the redetermination period from 1 year to 6 months, which means that people have to put more paperwork in more often to stay on the rolls. All those were efforts I shouldn't say effort, all those are things that will reduce Medicaid populations, not necessarily, well, the immigration one is not a big one, but the redetermination one could be. I don't remember an estimate I heard, but it could be several thousand people who just don't have the wherewithal or the capacity to carry that level of paperwork. So where the relationship is that would be a reduction in Medicaid, which means it would be a reduction in cost to both the state and the federal government over here, but then it could see it elsewhere within the system in terms of uncompensated care or untreated illnesses. Again, that just kind of goes into the speculation of how healthcare works, but they don't impact the provider tax. They're things that the federal government, when they were costing out their bill, okay, there's some federal savings here, there's federal savings here, there's federal there.
Thank you.
Does that help?
Representative Bodie?
Thank you. I think I heard one choice you have for policy levers, cut services for eligibility. I didn't think we could determine who's eligible and not for federal program.
We can in some populations. You
It's a
have,
state and federal partnership program.
yeah, you have, and if I ever do a Medicaid presentation or if you want one, there's two populations. We have what's called a mandatory population and an optional population, both population and services. Those are the populations and services that are required under the mandatory and the ones that are optional. So optional services would be things like dental, chiro, those kind
Prescription
of
drugs.
prescription drugs. They're all going to be optional. We can drop those. And then same with certain populations and certain services, like our V-Farm program or some of our expansion populations. Those are all things that we have with the allowance to reduce if we choose to.
When you get a chance, can you just send us the YouTube link or the date of the last time you gave a presentation like that somewhere so folks can watch it if they want?
Oh, on the HR one or on
Medicaid.
Medicaid?
Both things.
Sure.
Thanks. Yeah, nope. Recommend page. For example, go.
Well, you may have, I think I already know what the answer is.
You can't ask it right. If you know the answer.
Committee, but you can't do it on the floor? No, you can't. All the rules apply in both places. Go for it.
Thank you. I was just going to help our rural hospitals. You know how to answer that. And
That is.
all the funds that we're receiving for changes.
Health transformation, yep.
We can't use any of that for this.
Not specifically. I mean, you can't use it for services. You can't use it to make up for lost revenues. No, there are specific parameters for what it can be used for. Some of which may help the rural hospitals, but not.
Representative Hochul. And this builds on that, but when we expanded Medicaid, did we see a reduction in things like, rehospitalization and uncompensated care? And would we expect to see that shift back? And if so, when would we start to see it?
I'm not sure either one of us know how to
Yeah,
answer.
I know.
It's a great question, but it's not an analysis that neither of us have done. I'm assuming maybe it has been done, so the Blueprint or other programs. But what I can say is Vermont does have one of the lowest uninsured rates in the country, but that's the only measurement that I can really quote off the top of my head. And, one of the ideas behind our waiver in general was to expand population and improve health outcomes. I couldn't tell you if we've measured those, but that is the goal of what our Medicaid program, one of the many goals of the Medicaid program has.
Well,
This is fun, come on.
thank you. Well, that was your last slide. Thank you so much. It really was a fireworks show. Appreciate it. Folks, we are done for the day. If you haven't read all your reports yet, go read them. And we're back here tomorrow at 9. Tomorrow we have, I know what everyone can do for the next hour. The annual PBR report was released yesterday.
Oh, it's so powerful. I really enjoyed it.
I'm really excited about that because I was actually having this moment of really missing Scott Beck, who would act like it was Christmas when the report showed up in the committee room. So you are, and I thank you for that. We won't need to bring him back from the Senate. And so if folks could read that, actually, that would be great. And then we are then jumping into the Regional Assessment District report, which is also really exciting. And then in the afternoon, we are hearing about the governor's recommended budget and then taking our first dive into legislative language. I worked with Kirby to take the tax department's classifications report that Jake took us through, whenever that was, and turn it into legislative language, and the places where there were policy decision points. He's sort of highlighting the policy decision points as a way of us to work through next steps for that. And so we'll do that tomorrow at 2. It's going to be a really fun day. I'm pretty excited about it.
I don't see the PVR report here on the list of, items. Is that?
I'll send it to everyone now. I don't know why I'm sorry I didn't notice that you didn't get it, Saoirse.
Maybe I did, but.
Yeah, it's 2025, but that's it. No,